Welcome to Medscape. I'm Dr. Andrew Wilner, and today my guest is Dr. Joseph Servin. Welcome, Joe.
Dr. Wilner and Andy, it is a pleasure to be here to be talking to you today.
Thanks for responding to my invitation, and I'd like you to talk today about what was new and what was interesting at the American Academy of Neurology in the world of epilepsy.
I'm always amazed with all that we've been through this year that there's always new novel ways to be surprised by what was going on at that meeting. And this virtual meeting was definitely kept up to the level of expectations of previous years. I think the thing that most struck me is that because this year so many things had happened, COVID-19, a sense of racial injustice, which led to concerns about social determinants of health, a reinvigoration or reinterest in population health. I think the thing that struck me is that there were quite a number of extra projects, if you will, including one I was involved with, that basically looked at this issue, which is what is going on upstream to the management of the patient with epilepsy, not so much what's happening in the exam room. So that was, I think, the first element that kind of took me by surprise and happily by surprise, because it's good to see research in that area. The second thing I think was also seeing some results of some studies that have recently emerged from previous studies that have been ongoing. And I'm specifically talking about like the Moniette study, where they looked at what happens to children of mothers who are exposed to even newer anti-seizure medications. So those were the two areas. They were almost population health-based studies that kind of look at one, a unique spectrum with women, and another just looking at the issue overall. And I think that was the biggest take-home message for me from the 2021 meeting.
Well, let's talk about the second one for a second. Teratogenicity, of course, is a big concern. And with the older medicines, we know that there is some. And initially, there was a sort of a feeling that, well, the new ones are safer. And but that was kind of limited interpretation because there was limited data. So it all looked good because there was nothing good and nothing bad. So what about now? We have a lot more experience, a lot more data. Is it still true that the newer medications are, safer for women who are going to be pregnant?
I believe that it's starting to look like they do seem safer than what we knew in the past. And it's all about what you judge it against. In the last iteration of these studies, it was always about valproic acid, Depakote, and some of these first generation agents that really caused a lot of problems and concern. What we saw here, particularly in lamotrigine, levetiracetam, not so much. It's not, I mean, the verdict isn't completely out because you still need lots of data, lots of women, but it does seem to be a somewhat more assuring that they're not picking up some of these obvious or overt negative aspects. That doesn't mean that individually that can't happen and that you have to let down your guard. You still have to get perinatologists involved. You still have to be on folic acid, things of that sort. But the reality is it's not showing up to the same level of like, oh my goodness, we need to avoid this drug. This is a disaster. That didn't come out.
Well, that's great because, women with epilepsy need to keep their epilepsy controlled one way or another while they're pregnant. And we've learned that valproic acid, so that one's off the list. It causes developmental delay, neural tube defects, but we have so many other choices that really shouldn't be an issue. Was it still true that dosing matters?
I think to some degree, there is some element of dosing. I mean, these were checked at anti-seizure medication levels. And the reason I bring that up is that the same medications that were utilized in this study are
Hmm.
used for other purposes. And when they're used for other purposes, whether they are for mood management or for perhaps pain management, the dosing can be less and it may not have picked up to the same level. So, what I will say is that, again, the verdict isn't completely altogether in, but it does seem to be more optimistic than it has been in previous iterations of this study.
I'll put you on the spot. If you have to choose a medication, all other things being equal, for a woman with epilepsy, is there a number one or a number one or two that seem to be the safest?
I still believe in levetiracetam. I still think that the data still favors it. That's assuming that there's no contraindication from a psychological, psychiatric standpoint. But I think that that to me still arises at that level, and the study did nothing to dissuade me from making that to making a different decision.
All right. Well, I just want to add on a clinical note. If for those who choose to use levetiracetam, there can be pretty wide fluctuations of drug levels during pregnancy,
Right.
and levels are continuous, repeated levels during pregnancy, at least every trimester, and some will do every month to make sure that the level stays within the therapeutic range are important. Would you agree with that?
100%. That is one of the things involved with this particular drug. It's very water soluble, so there is going to be a lot of volume changes. It has a half life that can be somewhat shorter, particularly the immediate release versions. So you do have to kind of realize that when you're checking those levels, that being adherent to the medication is very important, and then just being knowledgeable over the change in volume that occurs over pregnancy, that you may have to adjust for that.
Do you want to comment? You mentioned earlier the research in sort of social epidemiological issues. Do you want to comment on that?
Sure. So one of the things that I will tell you, if I don't get completely disrupted by what I'm getting at this moment, is the fact that we had a lot of wonderful research that kind of occurred with regards to these social determinants of health. We did on one study that I was personally involved with, what occurred was that we had a study in which we examined the Arizona Medicaid population. And that's a very important point of extrapolation, because this involved anyone who had epilepsy, who lived in the state of Arizona, and by using claims data, had a clear definition of epilepsy to the degree that we can tell, to examine what happens in terms of management. When they get the diagnosis, how quickly are they managed, or are they even managed with the first step of treatment, which is a seizure medication? This is important because when you're a part of this Medicaid program, you have to fill out extensive evaluation information, from whether they cover your prescription, to whether it gets filled, to whether where you live, what's going on in employment, salary. I mean, it's like a treasure trove of demographic data. And this is to an insurance group that is considered to be one of the models of the US. So this gives you a picture of what good supposedly looks like with regards to this. When we looked at this, and there was roughly about 6,500 patients in the state of Arizona over our time period, we found a significant treatment gap, somewhere around the mid 40%, 45, 48%, that never got treated at all, regardless of that diagnosis. Then when we look to those that did get treated, if you got treated, the average delay was somewhere between 3 to 6 months, with 6 months being the more common number. And then we saw that certain demographic factors impacted whether you were delayed in treatment or whether you got no treatment at all. And those included ethnic group, such as being Native American, being unemployed, being homeless, having being widowed or divorced, in other words, where you were alone. Those were the items that all seemed to kind of play into the mix, and that was what was found in this situation.
Right. Well, I think it's, no surprise, but it's nice to sort of quantitate that. I've always been impressed that, epilepsy patients who need frequent visits, for example, can't drive. So right away, they're behind the eight ball. They got to come to the doctor, and it's very difficult for them to come to the doctor. Maybe telemedicine will help. I think that would be an interesting study, to see if telemedicine visits help the epilepsy population, that's stuck at home. And of course, many people with epilepsy have memory problems. Well, that's going to affect adherence. And it's so important for them to take the medication regularly, and yet it's so difficult.
And that was what was sad about it. So, I mean, even though we looked at in Arizona, the point is this is considered one of the model insurance, which means this may be as good as it gets in that group. Whether that what it looks like in commercial insurance, whether what it looks like in other groups, we don't know. But it does seem to be somewhat consistent with what's published out there on a national scale. And I think that that just kind of helps to confirm that we have a problem.
Well, Joe, this has been a really great discussion. I want to thank you for, well, just sharing your insights and observations of advances in epilepsy at the American Academy of Neurology meeting this year, 2021. Thanks very much.
It's so welcome, Andrew. It's such a pleasure to talk to you anytime. I always look forward to it.
I'm Dr. Andrew Wilner, reporting for Medscape.